Hi, good afternoon. My name is Ricardo Cahigas. We're going to be doing a thoracic and lung assessment. And this is my patient. His name is Tony. Initially, we will begin the inspection by visually inspecting the patient. We'll be looking at, again, when you're doing a thoracic assessment and lung field assessment, you just want to look at the actual rise and fall of the chest wall. Look at the rate of breathing that the patient is having. Prior to beginning the assessment, what you want to do is look at the patient's medical history and physical. For example, you're looking for signs that the patient has asthma, any type of structural kyphosis, or bending of the back or structures, anything that would indicate that you need to focus on during the course of your exam, or you may want to look at during the course of the exam. But again, for a normal patient, what you'll be looking for is looking for the visual inspection, looking for the rise and falls of the patient's chest, looking for intercostal muscle, use of intercostal muscles during the course of breathing. Again, you're observing inspiratory and respiratory respirations. You're looking to see if there's any tracheal tugging. Is the trachea midline? Again, the normal rate of breathing for an adult male should be between 12 and 20 breaths per minute. Again, during the course of your physical exam, you're asking them questions. You will assess and see whether the normal speech pattern, or they're short of breath, having difficulty speaking, or anything of that nature may indicate something during the course of the exam. Again, what we do is just move towards palpation. And again, what you're looking for, the patient demonstrates any pain or discomfort during the course of the examination. Also, you're checking for any crepitus, subcutaneous emphysema, things of that nature, anything out of the abnormal during the course of palpation during your physical examination. And again, you're doing a comparison from one side to the other. And again, the trachea, you're just checking to make sure that it's midline, checking from one side to the other, checking between the intercostal spaces. And again, doing a comparison between one side and the other. Again, you just going to ask the patient, have any pain or discomfort, anywhere you touch, again, that would indicate any signs and symptoms of something that may be, be brewing, or something that may be worried that you have the examination continue further assessment. During the course, we'll do the percussion exam, and again, we would do it more. You should do it during the anterior and the posterior portion of it. Again, what we'll do, we'll be checking for tactile phrenitis, which would be the transmission of the voice or sound through the lung field to the chest wall. So when you're doing tactile phrenitis, just use the palm of your hand. And again, what you're trying to feel for is see if it's equal on both sides. When I say the palm, I actually mean the side of your hand. I'm going to say 99, Tony?
99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Thank you. And again, you want to check between the intercostal space. You want to try it not to be above the bone. Not to be on top of the bone, because then you're going to get a false transmission at that point. Again, when you're doing auscultation, you want to start on the upper anterior portion of the lung, upper lung fields. You want to start above the clavicle. Take a deep breath. Exhale quickly. In and out. Again. Again. Good. And again, you're listening for equal lung sounds bilaterally on both sides of the lung fields on the anterior chest wall. We would just actually demonstrate direct and indirect percussion. And again, with just a slight palm of the hand, what you would do is just listening and feeling for resonance. Again, it's a dull sound. For indirect, you would just use your third index finger and the second the IP joint. And again, you're going to be listening for resonance. Again, go within an intercostal space. And again, it should echo on the lung fields. When you get to a bone or other structures, it will sound like a dull sound. And again, that could be normal depending on where you're palpating on. But if you're looking for the lung fields, when you're listening and looking for the lung fields, if you hear a dull percussion, probably indicates some signs and symptoms of consolidation. Again, I'm going to turn you around. Okay, when we're doing the posterior portion of it, again, we're going to be looking again for the rise and fall of the patient's chest. Take a deep breath for me, Tony, a little bit exaggerated. And again, in and out normally. Again, you're looking for the rise and fall of the chest, looking to make sure that there's equal expansion of both lungs. Take a deep breath. Good. And again, your hands and thumbs should move up symmetrically. And we're going to be doing the same thing. Again, Tony, 99.
99, 99, 99, 99,
Stop. Now, just when you're doing checking for formitis at this point, what you want to do is just avoid going over the scapula here, because obviously you have bone. You're going to get a different transmission. So 99, Tony?
99, 99, 99, 99, 99, 99.
Thank you. And again, when you're just doing the percussion also, you just want to make sure that you have to take the, don't do it percussive with the scapula, because you're going to get a dull sound, and it may be a little bit sleeping. It's very difficult to hear here, but I try to exaggerate it somewhat. But again, it doesn't resonate, it's a dull sound. When I go here, over the lung field, it sounds a little more echoes. And again, as I move down, what I'm trying to do is just map from one side to the other where the lungs are. And again, have a visual map. Again, you have the vertebrae, and again, during the process of percussion, you start to see from an anatomy that we're all familiar with, but also through percussion and listening to lung fields, get an idea of the lung sounds mapping. Again, we're going to auscultate from one side to the other. Take a deep breath. Good. Again. 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 Good. Now, what we're going to do is just go over diaphragmatic excursion. Well, again, normally when we're doing our percussion, what I would ask Tony to do is just take a deep breath and hold it. Take a deep breath, Tony, hold it. There you go. That's where it's here. There is dull. There I get resonance. Okay, so that's the bottom of the bases, and then go to slightly above. There you go. Okay. So we know here. What I can do is just go mark it with a pen. That way I have the baseline of where it starts. All right, Tony. Just go ahead and exhale and hold it. Take a deep breath. Go ahead and breathe normally, excuse me. Okay, I'm going to actually take a deep breath. Take a deep breath. Blow it out. Okay, hold it. And what I would do is just start from here. And again, I get that same difference of resonance here, and that's the diaphragmatic excursion. You're going to breathe normally. And again, what you're looking for is usually between a 3 to 6 or 7 centimeter, 3 to 6 centimeter difference from the where it ends and where it begins. And what that would just basically tell you is just the displacement of the diaphragm. In normal people, it's between 3 and 6. Usually in athletes, or probably people that are more fit, you're going to see it's between 6 and 8. This is the displacement of the diaphragm during the course of the respiratory breathing. Again, some of the adventitious lung sounds that you will be listening for, it would be wheezing, rales, bronchi. Probably would characterize rales and crackles almost as similar as the same thing. Wheezing basically will be bronchitis or infections of the bronchioles. What you're listening for is just air that's trapped inside the alveoli or within the lung field. And with wheezing, you'll get the traditional whistling sound, high-pitched sound. And bronchi, you just will get the inflammation. It's the inflammation of the bronchioles or bronchi. And you'll get the same thing. It's a little more wetter, but you'll be listening to that, listening for adventitious sound. With the rails or the crackles, it sounds almost like the hair. You know, some of the literature describes that if you were to take hair and you wear the rubber between your ears and get that wrinkling or crackling sound, that's what it sounds like. And again, for bronchi, what sounds like more of a coarse or hoarse sound that you're listening for. And children, again, you'll be listening for that too. I'm just going to probably stick to the adults right now. If the patient's has a history of complaining of pneumonia, for example, coming with a high fever, a cough, a chronic cough, maybe they have for some time, in order to rule out pneumonia or congestion or consolidation during the course of the exam, you could do 3 tests for different 3 tests additional tests that you can do, trying to rule out adventitious sounds. One would be agophony, the other one would be whisper triloquy, and the other one would be bronchophony. So we're going to go and use bronchophony right now. We suspect some type of consolidation. I'm listening to the lungs, and I sound like something may be possibly going on. What I would do is just ask Tony just to take, as he's taking deep breaths, every time my stethoscope touches him, it just say 99.
99, 99, 99.
Take a deep breath.
99,
Good.
99, 99.
And again, what I'm trying to listen for is see if there's any pneumonia or consolidation anywhere in the lung field. Again, we should hear If we were to hear 99, it should be sound slightly muffled. It shouldn't come through clearly. Would indicate that the sound transmits very much well through fluid or consolidation than it does through normal air. The other thing that we can stress for is whisper soliloquy. What do I ask Tony to do? Tony, just whisper 1, 2, 3. And again, I would listen to the same thing. Just whisper it, and I would check him, take a look at it while he's whispering. Every time my stethoscope touches, just whisper 1, 2, 3. I get it. Thank you. And again, I'm whispering. I'm observing the fact that he's whispering. I can see his mouth moving, but I don't hear him saying 1, 2, 3. If he had some consolidation to build up anywhere in his lungs, depending on what field it was, and especially if you're listening to the anterior, you're really going to get the lower lobes. You're going to hear. You would clearly hear him say 1, 2, 3. What you shouldn't hear is him say 1, 2, 3. That way, the sound does not transmit through consolidation that you wouldn't expect to be hearing or expect to be hearing. But again, if you were to hear the sound, it would indicate that there was some adventitious consolidation somewhere within the lung field. Agophony. Well, what I would do is just, Tony, just to say E. Every time my stethoscope touches your back, I just want you to say E. Okay?
E. 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 E.
Again, you're looking for some type of adventitious or unusual lung sound by the syllabus E. What it would normally sound like, it would be somewhere in the vicinity of sounding like A. What they call is the E to A transition. But again, we did the inspection, we did the palpation, we did the percussion, and then we did the three different techniques to listen for adventitious lung sounds. And that concludes my thoracic and pulmonary assessment. Thank you.